Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chimanchu. I'm here with my co-host Sam Mazer and our amazing producer Hartley Lidsky. Hi guys.
Hello.
Hey.
And it'll be Dr. Hartley Lidsky by the time this episode goes out, right?
Mm-hmm.
100%.
Excellent. And tonight our guest is Dr. Emmanuel Alalade to discuss treating pain in children. But first, Sam, do you want to remind us what's going on with the show?
I would love to, Chris. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Alalade, who is a pediatric anesthesiologist and pediatric pain physician at Children's Healthcare of Atlanta. He's also the co-founder of the Morehouse Anesthesia Pipeline Program to help increase diversity in anesthesiology. Dr. Alalade teaches us the biopsychosocial model of pain, the doses of every pain medication known to pediatrics, every single one, and the essential nature of multimodal pain control.
I'm excited to get into this episode. Let's alleviate any confusion about pediatric pain. Welcome back, folks. I have Dr. Alalade here, and thanks for coming on the show.
Oh, thank you very much. Thank you all.
Because we're an informal group, is it okay if we call you by your first name? I think you said Manny. Is that right?
Manny will be appropriate. Yeah, that's fine.
Excellent. Thank you for coming on this show. First, as we start to get to know each other, can you give a couple sentences of who you are and maybe something outside of medicine that you like to do?
I would say I'm a gamer. I'm a girl's dad, father of 3 beautiful children, all girls. I'm a pediatric anesthesiologist and a pediatric pain physician that's dedicated to mentorship, advancing diversity in medicine. I have a mentorship program at my institution.
Wow, I love that. Girl dad before doctor. That's really important. Can you tell us, Manny, what is your favorite failure in your career and what did you learn from it?
I would say not matching into neurosurgery. That was my first attempt in the match. And that was a humbling experience. I got more close to 30 to 40 interviews. I even didn't put some programs.
Wow.
And that not matching just like kind of helped me reshape what I actually want to do in medicine. Like it gave me an opportunity to kind of reassess, reset, I have to say. And I found like I enjoy hands-on procedures. I enjoy working in children. So when I saw the second time around, it was between radiology and anesthesia. I was like, I do not want to be behind the screen. I want to see patients, talk to patients. So I went to anesthesia and I haven't looked back since. And then when I did my PhD rotation, I loved it. And I love pain too. So instead of doing 1 fellowship, I did 2 fellowships.
Oh, nice.
And it's been the most pivotal moment in aligning my career with my values. And I've enjoyed it so much.
So no regrets for neurosurgery, huh?
Nope, not looking back. No calls.
Amazing. This is a group of mostly pediatric people who listen, but still, you know, we love our neurosurgeons, but also there's other opportunities where you get to do all these amazing things as well.
Exactly.
I mean, I'm also happy I didn't match into neurosurgery, but I didn't apply or match, but I'm very happy I didn't end up there by accident.
You didn't soap into neurosurgery, did you, Chris?
No, definitely didn't.
No, but that's actually a really good story. And nice to hear that, you know, if you keep moving forward, you can actually have a life that that is really what you want and what you're looking forward to, and you never really look back. And that's amazing. And it sounds like you have a wonderful family. You get to spend time with them, and you love kids and hang out with kids and work with kids all the time now. And it sounds like such a great story. So thank you for sharing. I'll ask the last question and then we'll kind of move into the case. So we do like to ask a best advice question here. That could be either as you've received as a learner or as a teacher or even in your career.
I would say as a learner, I would say ask questions. Like, because sometimes we're afraid to ask questions. And I've noticed people that actually ask questions are one that's going to shape the conversation. So one thing early in my career, I would say I was more sit in the back, keep quiet. But now it's about be inquisitive, asking questions, and that's much more enjoyable in whatever profession you do by asking questions.
I love that. I will say working for this podcast has made me much more comfortable asking questions to very fancy people. So
yeah, I was going to say as well, like, this is what we do. I'm going to ask you a lot of questions over the next hour. So we might as well find out.
But before we get any further, Manny, I'm going to ask, because you said it right at the beginning of your bio that you're a gamer. What game are you playing right now?
Right now, NCAA 25 just came out, 10 years. So it's been more than 10 years, right, for the last one. So I've been playing that.
I'll have to check it out. All right. Now we can get to the stuff. I just want to know what he was playing, guys.
All right.
Whether this is your first episode or you've been listening to us since day one, you know our goal has always been to share clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine. So let's talk about something that actually changed my day-to-day as a pediatrician: FIGS. I can't walk into a clinic or hospital without seeing people in FIGS scrubs. And I get it. I wear them too. They're incredibly soft, form-fitting, and durable. And it's not just us. If you've been watching a certain popular ER drama on TV, yep, they're in FIGS too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids and kids come with messes, I love that FIGS are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine 50 plus times and they still look brand new. All of that and so much more is why we've teamed up with FIGS. Now Cribsiders listeners can get 15% off. Just go to wearfigs.com and use code FIGSRX. That's wearfigs.com and use code FIGSRX for 15% off.
Well, sticking with the sports theme, tonight we have a case from the Cashlike Children's Emergency Room. So you're working in the Cashlike Children's ER when 5-year-old Howie comes in with his parents after a wipeout, after he attempted the coolest new skateboarding trick there has ever been. But tonight he is in tears, he's inconsolable, he's saying his left arm hurts, but he's in too much distress to answer any of your follow-up questions. He's holding his arm really close to his body and he refuses to let you or anyone else for that matter get anywhere close to it, which is making it really hard to do a thorough exam. So with this child, we can tell that he's in pain, but how do you approach assessing pain more formally in kids?
Usually I start by just observing the situation. Like you said, he's holding his arm if anybody from touching him, right? So those non-verbal cues. Also, I see his behavior. Is he withdrawing, agitated, sleep disturbances? Those are cues I kind of look for. And then I look at the family. The parents are usually the best historians. So like, what happened? What's different from his normal activities? And then, since it's all unconsolable, sometimes you have to address the pain first before you can start asking questions. So in this situation, if he has an IV, you might give him some medication like morphine or fentanyl to kind of get him to quiet down, able to get more probe, and also actually do a physical exam to know how extensive the damage is. So communication, assessment, nonverbal cues are the first steps.
So I remember when I was last in the PZD that I trained, on the walls they had these pain scales with all these smiling faces and frowny faces. Are pain scales useful when assessing kids?
Depending on age group, you can use the FLAC, you can use the faces. So in this age group, with 5-year-old, you can get the faces out. They can see from 0 to 10. Like, when it actually will be 0 to 10 for you, but I can see the faces when it's smiley, frowny, and just look at where's your pain number. Which one is like what you're feeling right now. So those are the kind of skills that we can use. There's revised FLAC for patient that's non-verbal. So you look at the faces, the leg, the activity, the cry, and consolability. And if it's like stiff, hatchback, unusual cry, those are things that you kind of cue. Between 0 and 2, you can see what the point system, and then you can give it a grade between those two.
And is that supposed to add up to the usual scale of 1 through 10? So you have 5 pieces of FLAC, is that right? And then
yes,
each is
exactly.
0 to 2, so then it's a total of 10 points. So you can use it interchangeably with our quote unquote 0 to 10 scale, is that correct?
Exactly. So as an adult, yes.
Okay, and that's how we're essentially supposed to use it, I imagine. Excellent. And then you also had mentioned that these children, you talked about kind of, or pre-verbal children or ones that aren't really speaking. You kind of mentioned all these things about watching how they're doing, observing them, parents, those seem like all things you can take to that group as well. Is there anything else that you would add that we should really know about for that type of young kid?
I would say for nonverbal with those dependent delays, those are usually undertreated, right? So they might not be able to say the same ouch or cry. Their facial expression might not be similar to what you expect in a typical patient. So that's when you kind of talk to the caregiver that's seen this kid for a long time to kind of say, okay, what are the things it normally does when he's in discomfort? What are the things that actually suits him? Is it like by touch? Is this a favorite blanket or his favorite pacifier? Those are things I kind of look for. And sometimes it might just be their perspiration might be one of the things. Or they're touching their belly. That tells them the sign of discomfort. So the caregiver is usually key in kind of getting those information, because this will be my first time seeing this patient. Typically, I've seen enough of these developmental delay kids that I know what I should expect. But if it's your first time, you want to talk to the caregiver, and that will be the best person to kind of give you how they normally feel.
What about on the other end of the scale? So we have a very verbal child, maybe an older child, or maybe a young adolescent or older adolescent, and you say, "Hey, can you give me a scale between 1 and 10?" And they say the invariable like 12 or 13 or 500 or whatever. Like, is it useful to think about in that way, or at that point you're just like, you know what, I'm going to use my other cues, and the scale has nothing to do with anything?
In that point, you look at a frame of reference, right? So I would say in this way, that's just our frame into families, is like, what could be a 2 to me? Maybe I'm just walking in my house, I step on a little toy. For me, it might be a 2 out of 10. But for my daughter, that's 4 years old, just stepping on that toy that was sharp, that'll be 10 out of 10. That frame of reference is different. And that's why, even when they told me it's 10 out of 10, you still want to listen, because communication is key. So at their level, I'll let them describe how they feel in their own language, in their own words. That is how you want to get the information from a 4-year-old to a 6-year-old. You go down to the level, get the information you need.
Gotcha. So you might ask, like, so what would a 10 be to you? Or are these questions that you're asking the child, or are these sort of just the way that you're talking about pain with families?
This is why I'm asking the child. It'll be like, okay, this is what happened. Like, what was the last time you hurt yourself? Like, tell me, what was the worst pain? When did you feel like your pain was 10 out of 10? They can give you the experience. Most people can recall when they had a bad experience. And then you can use it as a frame of reference to kind of say, like, after you give the medication, is it much better than that scale? And we kind of use that as a point of reference from now on. So when I see them again, we can go back and see, are we making improvements? Are we de-escalating?
Gotcha. I like that. So you're almost establishing like their personal pain scale, which may or may not stop at 10. And then using that as a frame of reference. That's really helpful. So in terms of treating pain, I think we have all learned that the first line is, good old fashioned acetaminophen. And I feel like oftentimes that's all that's needed. But do you have any tips for maximizing the efficacy of some of our favorite over-the-counter pain medications like acetaminophen or NSAIDs?
I love Tylenol, I love ibuprofen. But one thing I've noticed time after time, when patients have had chronic pain that's been more than 3 months that comes to our clinic, or if I see them on the floor or in the ED, it's like the people underdose them. The dosage itself, 15 milligram per kilo every 6 hours, or 10 milligram per kilo for ibuprofen, people underdose. And even then, the issue is like they don't actually stagger it. It's like either or. Using this all around the clock, using like a around the clock approach would be better. So if you start at 9 a.m., Tylenol every 3 hours, ibuprofen at 12, you stagger it, that would lead to a better pain control versus just picking one versus the other.
And I'm curious also if there's, let's take acetaminophen, right? So we're talking about 15 mg per kg for acetaminophen. We're talking about 10 mg per kg for ibuprofen. Is there a maximum dose? A lot of times hospitals like, the biggest pill is 500 for acetaminophen or 650 for 2 of these 325 pills. Yeah, what size would you say this is a quote maximum dose?
I would say for 400, ibuprofen will be 400 milligrams because and do that at around Q6. And then you can go to 400 to 600 depending on the weight. And then for Tylenol, I would say between 650, not to call levatoxin, 3,000 is the max. So I do 60 milligram Q6 around the clock.
Okay. Because that's a good way to underdose someone, for example, if they're very large, we are saying, oh, we're going to max them at 500 or something like that. But you're like, oh no, you should really max at 650, or if you're maxing at 650, you should max at 975, something like that. That's a good way to underdose versus the young infant is like, okay, it's pretty easy to make per kg them based on their weight. Okay, so you mentioned staggering, so every 6 hours, but if you adjust it so you get something every 3, that's very helpful. Any other tips or tricks we should know?
Using topical agents like lidocaine, Voltaren gel, those are things that most people don't consider in little scripts and cuts. So also, I would say just using distraction too, like video games. It's like we do not have to use medication for all aches and discomforts.
I love that. And I think this is a great time to shout out some of our child life colleagues who do really, really wonderful work in this space. But it's also our responsibility to our patients as well to remember that non-pharmacologic strategies exist. You mentioned distraction. Are there other techniques that you often use or employ with kids?
It depends on the age group. So let's say for infants, when we're doing an LP for spinals, we do for regional anesthesia, we do a Sweeties. All right, we do Embla to the bag. You can do sweet solutions, swaddling, put the parents at breastfeeding. That's one thing to do, like a eel stick. Soft music, brown noise, which is one thing I just learned, actually suits them out. Because when I'm in the OR, we do spinal anesthesia and we play the brown noise and the kids just fall asleep. So brown noise, white noise, their parents' voice, those are things singing. Those are things that could be a pharmacological strategy for an infant. Then for toddlers, you have the bubble toys, the iPads. My daughter loved iPads. Give them a phone, they can play on it. Show and tell techniques, play therapy, you have the dolls. In the OR, we have the mask over on a baby so they know before they get their mask on their face, they see what it looks like. We put this blood pressure cuff on the baby so they can mimic that, they can see that before we actually do it. And then just touch with a blanket is another thing they can do for like toddlers and preschoolers. For school-age children, you can think of virtual reality. That's a new thing that we're doing more research and we can see is actually alleviating pain in more studies. Music therapy, breathing exercises. So it just depends on the age group. And then as you kind of get older, once you become like a teenager, we can start doing biofeedback. And biofeedback is when you use your own physiological response to kind of calm down. That means we put electrodes, get your heart rhythm, your breathing, and just by taking deep breaths, you can see how your pulse, your breathing, your temperature kind of comes down. And you can see those vitals slowly come down. You can do relaxation techniques. We have the app Calm. I have it on my phone. Headspace on my phone that I use when I have stress, and it kind of helps me kind of get my vitals and my chi down, like I say it. So those are things that we can use that's non-pharmacological. And then we have a pain psychologist, which is key, teaching all those CBT techniques. And then you can have acupuncture, you can have also massage. Those are things that's non-pharmacological that can actually alleviate pain.
Wow, you threw out like a whole bunch of different things, and I don't think we have time to talk about every single one of them, but I do want to sort of clarify a couple of different things. So the first one is, you said brown noise. I have no idea what brown noise is. Is that something like white noise? How is it different?
It's similar to white noise, but it was just like much, I would say, I don't know if it's say darker, but it was different. Gotcha. One of my new age mentee is one that actually brought it up, and I was like, never heard of this, but let's try it. And we could see the effect on the patient. So I guess when they're studying now in colleges, brown noise is a new thing.
I guess we'll have to Google it. We'll tell our listeners, please Google brown noise and see what comes up. But just so you know, it works.
I just Googled it. It says something. So it says brown noise, which is also known as red noise, apparently.
Exactly.
Whatever color, is a type of noise that is dominated by low frequency sounds, creating a rumbling bass. I guess that's not a bass like a fish. Bass-like sound. So this is what happens when you read it. It's characterized by its lower intensity at higher frequencies compared to white or pink noise. Apparently there's a pink noise too. So I guess lots of different noises out there. So you said biofeedback, and I think some of the things you were talking about sort of relate also to chronic pains.
Yes.
I'm wondering, can you use some of these things in this acute setting? Like how would you use biofeedback in an acute setting? Could you explain that a little more so practically?
So that would be in setting of acute or chronic pain, right? So acute flies, like sickle cell crisis, you can have somebody have complex regional pain syndrome that's not having a flare-up. It's an acute pain in a setting of chronic pain. And using those techniques actually help us reduce the intensity, the frequency of those pain flares.
Gotcha. I think that's what you were talking about earlier too, with that folks tend to underdose Tylenol and ibuprofen, especially for kids who have some degree of chronic pain and are on these medications long term, and then now they're in the hospital with some acute problem.
Yes, exactly. So with our sickle cell population, you can see we have Tylenol, which we kind of schedule around the clock. Ibuprofen, we use Toradol initially, but you have to maximize it. The max dose is 20 doses. So because we want to protect the kidneys. So we transition to ibuprofen, and which you can take after the maximizing on the potency of Toradol, which is ketorolac.
Let's be honest. No one starts a business for the joy of calculating tax withholdings. That's where Gusto comes in, to take the stress out of payroll, benefits, and HR so you can focus on why you started your business in the first place. Now, speaking from my own experience, when you're running a small business, the admin tasks pile up fast. Onboarding, paperwork, it all takes time. And when you're also busy working in the hospital, that time is something you just don't have. That's why Gusto is such a game changer. Gusto is online payroll and benefit software built for small businesses. It's all-in-one, remote-friendly, and incredibly easy to use, so you can pay, hire, onboard, and support your team from anywhere. They make things simple. Automatic payroll, tax filing, direct deposits, health and commuter benefits, even 401k plans. Gusto has it all. Gusto has options for nearly every budget, including unlimited payroll runs for one monthly price. No hidden fees, no surprises. So if you're like me and you want to spend less time drowning in paperwork and more time focusing on the work that really matters, give Gusto a try. Try Gusto today at gusto.com/Cribsiders and you can get 3 months free when you run your first payroll. That's 3 months of free payroll at gusto.com/Cribsiders. One more time, gusto.com/Cribsiders.
One question I also have is, I know in some of the adult ED literature, they have looked at using a combination of Tylenol and ibuprofen together at the same time. I mean, this is something that I sort of do with some of my, when I talk to my parents as they have kids with fevers and stuff, because no one can ever remember which one they took last, the ibuprofen or the Tylenol. Do you know of any other studies using Tylenol, ibuprofen at the same time and then sort of dosing it that way instead of trying like, what was the last one we had 3 hours ago or whatnot?
Usually, this is the first time I'm hearing about dosing it at the same time, because the concern with that is what happens when that pain picks back again. Do you have to go on an opioid? And usually in pediatrics, we try to avoid opioid as much as possible. I think that's my concern. I could see if it's a mild pain, I could see a mild to moderate pain, how that will work. But I'm very reticent in suggesting that, at least expert opinion-wise, in using it at the same time in the pediatric population.
You know, before we move on to our next topic, I just wanted to complete the acetaminophen and NSAID conversation for one last piece. And that is side effects, downsides, things that we should be worried about. So, you know, at what age is it safe to start both of those medicines? And afterwards, what side effects should we be most worried about, and anything that we can do to mitigate those?
So for ibuprofen, I would say it's 6 months of age you can take outpatiently. But we both work in academic institutions in which you give ketorolac to neonates and infants. But I would say make sure that at least for the outpatient pediatrician, it should be 6 months higher. And you worry about kidney function, you worry about side effects. Some people get drowsy on that ibuprofen, which is a common side effect, and also the GI side effects. So always have it with meals to protect the GI distress, and also and also make sure you don't take too much. You might have to get labs, maybe a basic CMP or BMP every 6 months to a year to make sure that the kidney is not affected if you're on the lifelong. For the Tylenol, I would say it's mostly for liver protection. So 3,000 max dose, and try to keep it under that. If you're taking more than that, then talk to your physician to find alternatives.
That's helpful. Unless anyone else has other questions about over-the-counter pain, amazing. I'd love for you to just talk a little bit about racial disparities in pain treatment. I know we've sort of brought up sickle cell has already come up in the conversation, but I'm curious sort of how racial disparities show up in pediatrics in particular, and what we can do as clinicians to move towards more equitable practice in our own practice, and then sort of as a system level. That's a lot. That's a big question.
Yeah, in this time of age, it's on point. I would say studies have shown Black children are less likely to receive opioids in ED for fractures compared to white children. Even when you control for the severity of the injury, the insurance status, vital signs. So this disparity is not just on maternal morbidity, it goes down to our children too. And also, in one study, medical trainees think because Black people have thicker skins, they don't have sensitive nerves, their nerves are less sensitive, which is false. And these are things that you kind of grow, either old white tales that you kind of hear, and people kind of like English shade into their practice. So how can we kind of change this? Is being aware that all of us have biases. I have biases, and just doing those implicit training and putting them into action, knowing that I just need to listen to the family, regardless of any kind of preconception I might have coming in. Because most of the time, people just want to have someone that will believe in them and listen to them. And I think that's how we can kind of deal with it. So know our biases, listen to the family without any kind of defensiveness. And because they know by the way you talk to them, by the way you look at them, if you believe them or not. So those are things we can use to kind of break down these biases and stereotypes.
And I had a follow-up question. I was just curious, is there anything that we see more in pediatrics or different in pediatrics than we see in adult medicine? Because we know those biases and that kind of disparity also exists in adult medicine. I was just curious if there's anything that we'd say more pediatric specific.
When it comes to that, I would say it's mostly the parental aspect that's much different. Because if you make an implicit bias on the parents, eventually it's going to roll down to the child. And I think that's the two things that we need to be able to know, that you do not punish the child because of the parents' sin.
Yeah, for sure. Awesome. And we're going to try to talk about in the next kind of part of the case about how we should be doing these things and how we should do it academically and equitably. So, Hartley, you want to keep going?
Yeah. So to go back to 5-year-old Howie and his arm injury. So you consult orthopedics from the ED, and you determine that Howie actually did quite a number on his arm, and his imaging shows that he has a complex fracture that will require surgery. So at this point, we'd love to talk a little bit about perioperative pain management and surgical pain management. So could you talk us through how you approach perioperative pain management in children?
As a pediatric anesthesiologist, so I get to see these patients coming from the ED for their fracture. So we start very early on, even before they get to the OR. So that's where the ERAS, or enhanced recovery after surgery, kind of really shines, right? It's not just a protocol, it's like a philosophy, right? We load them with non-opioids, so acetaminophen, Tylenol. They get that in pre-op. They get ibuprofen too when appropriate. And then we apply regional anesthesia. So for a upper extremity fracture, we have manipulative brachial plexus blocks we can do. So a supraclavicular block, infraclavicular block, interscalene block that will give you analgesia of about 12 to 16 hours, depending on what kind of adjuvants you use. That means the patient will kind of be pain-free, and then you can still have your multimodal Tylenol, PRN, ibuprofen PRN, opioid if necessary as a PRN. And then we get them early ambulation, early moving. Those are part of to get the GI to be back to be moving again, so you can have a bowel movement. So that is part of the early recovery after surgery. So we aim for a multimodal to minimize opioids. We don't avoid it, but we try to minimize it because that could lead to constipation, ileosis after surgery.
I think let's actually talk about opioids first, and then I actually want to get to the procedural pain management and those regional blocks that you mentioned. Because I actually do have some questions, but let's talk about opioids first, because as the general pediatricians who are no good at regional pain blocks, this is probably what we're going to pull first. How do you kind of approach using opioids in this manner? We'll just kind of leave that open-ended, and then we'll kind of go after smaller questions then.
It starts with conversation with the family, because nowadays everybody has this with the opioid crisis. Opiates are not the enemy, they're the tool, but we use them carefully for the shortest time needed, and always have a plan to stop it. So I emphasize that I know the side effects of nausea, constipation, pruritus, itchiness, and sedation is there, but we use the lowest possible for each patient, and we titrate to effect. And after I kind of explain it to family, most of them are really agreeable for me to use it, depending on the name, fentanyl, which has a bad name right now, or morphine. They're willing to actually accept and use it for their child.
Awesome. So you're talking about titrating to effect. Where do we start? Which one do you pull first? Why should we do that? And then tell us how to move our way and move up.
Depends on the situation. Let's say you have a patient that doesn't have an IV. So my first preference would be intranasal fentanyl because I can dose it by just going intranasally, and that will give me that pain control immediately that will allow the kid to be able to be easily assessed. Like our first child, in which he was crying, moving, you can, once we kind of give him intranasal fentanyl without an IV, you can calm down, we can do a full assessment and then make a plan afterward. We can secure IV afterward. If they're MPO, I might go toward morphine. So I'm a fan of ibuprofen because I think morphine is even though it's easily titratable, it's easy to remember to know the dosage. I think ibuprofen has less side effects than morphine. But the issue is you have to still dilute it, and then you can have error with dilution. So I understand why most people prefer morphine because it seems simple to remember the dosage, 0.05 to 0.1, and also the way it's formulated is easy to kind of get 2 milligram, 4 milligram, 6 milligram. But I have a preference for ibuprofen versus morphine. And if the patient can take a PO, then I'm okay with oxycodone. I'm not an expert opinion. I do not have a preference for the mixed Tylenol plus hydrocodone or oxycodone. I like them separated, so I can alternate them for better pain control. So oxycodone Q4, Tylenol Q6, and just alternate as best.
Awesome. And let's just kind of talk about some dosage just because we want to make this so practical for our listeners. So when that kid came into the ER, 5-year-old, and can't even get an exam on it, you're like, all right, let's do some IN fentanyl. What are you starting with for IN fentanyl? How do you dose that?
I would start between 1 to 2 max per kilo for the kid. And usually I try to round to the nearest even number. So I would say it comes to the 50 max per 100 max per 2 ml. So 50 max per 1 ml. And then you can kind of round to the nearest even number. And that's what I kind of pretty much use. So 1 to 2 max per kilo.
All right. So we calm him down. We get an IV in him. And we say, and he's like, oh, I'm actually in a lot of pain. That fentanyl wore off. Let's do some hydromorphone. What do you want to do how do you dose hydromorphone for him?
With that one, I start very low. So 0.01 to 0.02 mix per kilo. And that you can give every 3 to 4 hours.
Excellent.
For morphine, will be 0.05 to 0.1 mix per kilo. Similar every 3 to 4 hours.
And I imagine most of these kids that you run into don't have any kidney problems or where they're going to back up morphine comparatively. So it's less toxicity that you're concerned about for hydromorphone. You just think it has fewer side effects as far as like maybe nausea or
exactly
pruritus, as you were mentioning,
sedation or pruritus.
Okay, awesome. And then we're like, okay, he's doing good. We calmed him down. We're starting to give some oral so they can last a little bit longer for him. How are you giving your oxycodone?
I start low for oxycodone, 0.05 mg per kilo. I know some people do 0.1 mg per kilo, but I usually start 0.05. And if they need more, or if the frequency is higher, I might go to 0.1 mg per kilo. But you have to tell me. The body of the patient has to tell me before I titrate up.
And then as far as the IV fentanyl goes, do you even use that, or is it just used as an IN situation in order to get them in their nose?
As an anesthesiologist, we use every fentanyl or that for induction. So if I come into the pre-op area and that patient is in distress and even moving them to the bed might be just so uncomfortable, pulling the intravenous fentanyl would be appropriate. So 1 to 2 max per kilo.
Awesome. Trying to think of what other questions. Hartley, do you have a question about how to do the opioids? Yeah, go for it.
I have so many questions about I have 2 questions. One, do we ever use PCAs in kids?
Yes. So
how does that look?
There's actually 2. Right now, they have PCAs, which is patient control. I think that's challenging in a kid less than 8 years old. Because one thing for you might be able to say, okay, my pain is kind of rising. Let me push that button. For them, it doesn't really hit them because they're distracted by other things till it's 10 out of 10 pain. So in that scenario, some institutions actually start nurse control. Instead of PCA is NCA. So the nurses actually push it for them because they can see the sign, they can assess with the flag scores. So we do use them for kids in pain. You can do a continuous, which is a Bangra dose to kind of upload them, and they can push a demand dose, which can be with a lockout of every 10 minutes, 15 minutes. So if it's every 10 minutes, you can push it 6 times in an hour. If it's 15 minutes, that's a lockout, it's every 4 times. And that's how we kind of use them to kind of like win them off too. We can start as we see their pain is getting better, we can win up to 15 minutes to 30 minutes and then discontinue.
Gotcha.
So we do use NCA and PCA in kids.
Yeah. What are your typical doses of, and what opioids are you using in the PCA?
So you can use morphine, you can use fentanyl, and you can use idomorphine for those one. For idomorphine, let's use as classic. You can do 1 to 4 mics per kilo per hour, or you can use between 1 to 4 mics Q10 minutes too. That as your dosage.
Okay. Gotcha.
I got one other question, unless you have one related to the PCA NCA.
No.
All right, more meds, more opioid meds. We just got to make sure. What about partial agonist meds? So this includes, buprenorphine, nalbuphine. Do you use any of those in your practice, or is it less seen because you see a lot of surgical pain?
So Nubain you can use for surgical pain, but it's less widely utilized. For buprenorphine, it's in selected patients. I know when I was in residency, we used buprenorphine for the geriatric patients after procedures. Right now, we're using it most commonly because the IV formulation is not really utilized in pediatric population. We have the patch and we have the sublingual. That was much utilized in the sickle cell population. As when because they've been so exposed to opioids and the euphoria that comes with it and the concern for addiction, we have not transitioned majority of those patients to now buprenorphine. So I would say it's selectively used, not widely used in pediatrics.
Cool. I have, switching gears a little bit, I have like a pain medication dosing question. So it's 3:00 in the morning and the nurse calls me and says, the patient is sleeping super soundly. Do I have to wake them up and give them their pain medicine if they're asleep? What do I say?
No. Do not wake them up. Let them sleep. When they are awake, when they they will wake up and you can give it them. Because I want the kid, because restful sleep is restorative. That helps with pain too. Because if you ask patients when they're in the ICU, every 1 hour vital checks, it's more disruptive for them. And if they're not in pain or distress, I would say let them wake up and you can give it to them when they're going to the bathroom, or if you see like, oh, they're awake now, but I will not wake them up to just give the pain medication, especially narcotics.
That is helpful. I think sometimes I hear concerns that we'll get like behind the 8 ball or then the pain will be worse because we didn't give the pain medicine when it's due, and now we're like, is that?
I understand that concern, but usually if the patient is sleeping soundly, it's because their pain is being well controlled a little bit. If they're not, most of them they are in pain or discomfort, they usually because they're still having discomfort and pain. So I would aid toward you can find opportunity to give the med without waking them up.
So I'm probably going to bring up the next kind of topic here from this perspective. We have our multimodal pain regimen now. So we have our opiate pain measurement or pain management plan, which is like oxycodone, we'll say every 4 hours. We've added acetaminophen on top of that. We've added ibuprofen on top of that, for example. We've kind of staggered them the whole way. Are there any other medicines you'd add to your multimodal pain regimen in children?
We have a lot. I would say Tylenol, acetaminophen, ibuprofen is the foundation. That's how we start. Then you have gabapentin or pregabalin or Lyrica for your neuropathic or surgical nerve pain. You have ketamine low dose, which is an infusion in which we now use for opioid sparing, sedation, also for neuropathic pain like gabapentin. You have dexmedetomidine or Presidex for the sedation analgesic because it's alpha-2, that would not cause any kind of respiratory depression. You have lidocaine infusion that you can do that's been shown to actually be a potent, like a morphine or narcotic, because if you see it's like equivalent of narcotic or morphine to us. You can use for abdominal cases, neuropathic pain. Then you have clonidine, which is a patch. You can have it as an IV. You can have it as an oral medication that could be actually a sleep aid that could help with also pain too, because the alpha-2 similar as Presidex. And then you have to have your stool softener too, your antiemetics. Those are things. You can have your Nubain that could act against pruritus too, if you have some itchiness from like a epidural or intrathecal pain procedure. And
you mentioned, I feel like for us, like we're probably not going to be prescribing ketamine or Presidex or one of those pieces in that case. But clonidine we can do. I was going to ask actually about the pregabalin though. You had mentioned the Lyrica pregabalin versus gabapentin. Can you kind of walk us through when those things should be used in pediatrics and how you would use them?
So when it comes to pediatrics, I would say when you kind of have concern of like a neuropathic pain or surgical nerve irritation, I think that's when it kind of comes to mind. they will tell you it's like burning, tingling, electric. Those are when those medications kind of start. But you want to rule out any kind of what do you call it, pathological cause, right? Is it like a spinal neuroforaminal irritation? Is this what's causing it? Because that might need surgery, not just medication alone. So I would say that's when you kind of lead to a gabapentin. And the dosage, usually you start about 5 milligrams to 50 milligrams per day, and you kind of titrate, because side effects is usually the reason we kind of like slowly, because you get really drowsy, you get sleepy, and most people kids don't like that. They can kind of off on that medication. So that's why everything's kind of start low, between 5 to 15 milligrams per day, and you divide it in 3 doses. And usually I kind of go slowly, with like up to 3 to 5 days before I go up to another dose. Like just with TID, right? AM, I start at night because I know it's gonna make you sleepy. So like we start at a low dose at night, 5 milligrams per kilo. And then if you tolerate it for 3 days, no side effects, no drowsiness, you add in a second dose in the morning. And then if that does well after 3 or 5 days and you have no side effects, then you can go up to the TID. Usually to be a safe, easy to remember, 1 pill for a week, then go up to BID for the second week, and go TID for the third week, if no side effects.
So it sounds like we're getting to 15 mg per kg per day divided 3 times a day by just adding another pill rather than going up on the dose, and then we could possibly go up.
Exactly.
And any reason why you'd recommend pregabalin/Lyrica over gabapentin or vice versa?
I would say the insurance is going to be a challenge until you get for Lyrica. You cannot go. Usually right now, I think it's approved only for fibromyalgia. But if you get into Lyrica, if you fail gabapentin, but you have to show that you failed gabapentin on the practical.
And now, unless anyone else had any other comments about this, I'm probably going to go back to the procedural pain management. You guys have any?
I was going to ask if we could just talk about clonidine for a second, and when you think about that and how you use it.
So for me, because I'm a chronic pain physician, so I ask everything about their school, our social life, our sleep. And usually when sleep is affected, I try to find a way to, is it insomnia? Are they trying melatonin? Are they using a good sleep hygiene? Is the TV off? Is the phone out of the way? Are they getting a shower before they go to bed? And if they fit all those true and attempted techniques, then one of the best medication I have is clonidine. It's not addictive. It's not something you can abuse. And we can start a low dose. And usually for a teenager, 40 kilo, 50 kilo, I can start at 0.1 mg at night. Actually, you can get to sleep and get restored with the sleep, which is going to help you with your pain.
Nice.
Cool. But not so much in the acute setting.
No.
All right.
Sam, you want to talk about procedural
I did, because I
pain?
actually had a fair amount of questions about the blocks. So you had mentioned that you can come in as a anesthesiology pain specialist and do some blocks, especially when you're going to and from, or peri-procedurally at the moment. What are the indications that you would do these for? When should we call you for this procedure?
So I would say so usually the surgeons kind of dictates that, like if they want a block or not. So it's a communication between us. But for a pediatrician, I would say if you have a pain that you're on opioids, and you have been challenging in providing adequate analgesia for that patient, and you've exhausted all your efforts, I think consult your pain team, and they can make an assessment if a regional block will be amenable. Because you still have contraindications you have to worry about. If it's infection, coagulopathy, sepsis, those are all contraindications for us when it comes to doing a regional anesthesia. So I think it will be a case-by-case basis on which regional anesthesia is amenable. But if you're going to the OR for a surgical procedure, most of the time we will get a regional block.
Because one of the, whether you call it pros or cons, is it seems like it is not a very long-lasting treatment. You quote 12 to 16 hours. I feel like I've seen this stuff wear off after just a couple hours.
Well, what kind of blood
I don't know. That's what I was going to ask. Like, it seemed like it was like bupivacaine or something like that. I don't know what they're using and why they're using it. I know nothing about this. I was hoping you could kind of fill me in on that. Yeah.
So when it comes to, like, if you say a block that lasts 2 hours, I would say one thing is, like, I would not call a local field block by the surgeon as a block compared to what we are doing, because now we are targeting nerves and we are letting it soak in for those lungs, and they attract those receptors, and that's how it kind of gets to prolonged blocks. You have ropivacaine, you have lidocaine, you have bupivacaine, and those are from some intermediate to now long-lasting local anesthetics that we have. So that's why you can get those 12 to 16 hours with epinephrine if you add it to it, or you can add adjuvant like Presidex, and that will get those long durations. So I think if you're talking about local feed blocks, yeah, within 2 hours they'll wear off. Like you add an incision, you can infiltrate the skin. Yes, those one I've seen, an hour to 2 hours, it will wear off. But a targeted block from a regional anesthesiologist, it should last you at least, I would say, at lowest 8, max 16 hours.
And I think, my understanding is the point is that it's a bridge to something, I would imagine. So we're bridging either to the
Exactly.
operating room, or we're bridging to our next medicine, or we're bridging to treating whatever underlying illness that we have going on to help us get to that. Is that a good understanding of that choice?
Yeah. So a typical patient that has, let's say, has a malignancy coming in for now an exploratory laparotomy to take out that malignancy, we know it's going to be a big incision in the abdomen. We know if they're not able to be, that would limit, if the pain is not well controlled, that means going to have some respiration depression there, the atelectasis, the ileus, because of the opioids they're using. So we can do an epidural that will target the dermatomes where the incision is made, and then we can give local anesthetic that will be continuous over 3 to 5 days that will help us minimize those opioids as best as possible. And we know the pain peak will go, at least for the first 3 days might be painful. We expect to kind of come down by after day 3. And if we can help us bridge that gap, that means the ileus we can avoid. We can encourage ambulation, and we can get them back to oral ingestion and going, and then having successful outcome outside the hospital.
Awesome. And so the epidural sounds like one that we can last for a little bit longer because it's a continuous infusion. Are there any other blocks that we should know about?
We are doing more fascia plane blocks. We call it erectospinal block. These are spinal blocks in which you put either a single shot, in which kind of numb the area that kind of the dorsal rami that kind of numbs the truncal area, or we can do what we call targeted nerve blocks, like a TAB block, ilioinguinal nerve block, in which kind of targeted to kind of numb the belly, to the whole belly, and that will give you the around 8 to 16 hours too.
Hey, Cribsiders listeners. Today we're going to talk about Claude from Anthropic. Claude is the AI for minds that don't stop at good enough. It's the collaborator that actually understands your entire workflow and thinks with you, not for you. Whether you're tackling a complex project or just trying to get a little more space back in your day, Claude helps extend your thinking to tackle the problems that matter. And if you've been listening to us for a while, you know we've been discussing how AI is shaping medicine. In fact, in episode 135, we dove deep into how we use AI in large language models in pediatric medicine, both the ways to improve efficiency at work and the guardrails we must put in place. That conversation really showed us just how powerful these tools can be. And of course, not all of our AI use is serious. Chris has been using Claude to make original AI poems at the end of each episode, so stay tuned to the end for this one. But beyond that, Claude goes much deeper than your average AI. It can analyze complex research, surface insights across tons of sources, and even connect with your professional tools like Google Workspace or Notion so everything's in one place. It's not about shortcuts, it's about thinking better and more creatively. So Cribsiders listeners, are you ready to tackle bigger problems? Sign up for Claude today and get 50% off Claude Pro when you use our link claude.ai/Cribsiders. That's claude.ai/Cribsiders right now for 50% off your first 3 months of Claude Pro. That includes access to all of the features mentioned in today's episode. It's claude.ai/Cribsiders.
Back to our patient Howie. So he does well with surgery, and he, goes on, lives his life, masters that skateboarding trick, no further injuries. But now he's back in the hospital. It's 10 years later. He's 15 now. And he presents to the ED with 10 out of 10 abdominal pain and is diagnosed with idiopathic pancreatitis. Ooh. So now you're a pediatric hospitalist and you're really struggling to manage his abdominal pain despite acetaminophen, despite NSAIDs, despite opioids, all the things we talk about. So when in this case should we consult a pediatric pain management team? And what should we have tried before we call you?
I would say one thing I always tell everybody, I don't care if just call me early. I rather call me early than call me too late. But I would say what you have tried, acetaminophen, ibuprofen, at least not around the clock Tylenol, at least morphine or opioids, but just something that is scheduled. We can see, is it helping or not helping? Because that information kind of guides what I'm going to do next. Like if we've tried opioids, either ibuprofen or morphine, and you're still saying you're still having challenges and it's adequate dosage for his weight, I might consider, I will try continuous PCA and a demand. Or if that is not working, I actually go down to the ketamine infusion, because that one has been shown to actually help in minimizing like in pancreatitis opioid consumption. We can use IV lidocaine in a patient like that. But if we haven't tried the adequate dosage or a PCA in this patient, we know it's at pancreatitis, we know he has to have some bowel rest. I think those things I will expect to be tried first before calling us. But if you have this patient has been just been a challenge, how about you call me early than too late?
From a practical standpoint, can you? I know that many of us probably won't be using a lot of ketamine, and we're probably using sub-dissociative dosing for it. From what I understand, it's possible some of our PEM fellows out there or those pediatric interns who want to go into emergency medicine, they might be looking at possibly doing this in their emergency departments. Can you discuss a little bit about how you would dose ketamine and sort of how you would explain this to the patient and parents?
So if you're using it is this for procedural or is it for just the idiopathic pancreatitis?
I would say for sort of this, you're trying to get their acute pain a little better control. So non-procedural.
Okay, so the way I kind of like explain it to parents is saying that like we've tried the narcotics approach, we have seen minimal success, or we haven't experienced more side effects. How can we minimize those side effects? That's where ketamine, low dose ketamine come in place. And they worry about like, is my kid going to be trippy, loopy, are they going to have side effects? And I mentioned them at the dosage we're using, which is sub-anesthetic, mostly anesthesia dosage, which is like 0.1 mg to 0.2 mg per kilo, which is pretty much, I would say, we maxed out at my institution at 10 milligrams per hour. It's very small. And it just addresses the analgesia component. So in those conversations, family are actually more receptive because I am not trying to get them kids sleepy or sedated. The kid will still be able to have a conversation. You can still talk to them, and we can still get the opioids down. And once we mention that we can get the opioid down, they are willing to try it. And then we can, at the next day, we're willing to see like, oh, we cut the opioid down by 25%. My kid is still comfortable, and we're able to like kind of transition them to an oral regimen and a winning pattern that's successful.
And for that ketamine piece, just, for safety concerns and things like that, we didn't say it out loud, but procedural dosing, if we're going for sedation, maybe 0.5 mg per kg up to, 1 mg per kg is your first induction dose, something like that. So we're talking a tenth of that dose, but we are doing it.
A tenth of that dose, exactly.
And most of us know opioid side effects. Are we still going to run into side effects with ketamine at that low dose? Are we going to run into lots of secretions? Are we going to run into laryngospasm? Should we know about those things, or is that not even close?
You will not be running into laryngospasm. You can still have some sedation because everybody's sensitive to medication. Some people are more than the others. So they might be saying, oh, I'm seeing colors. Oh, I had a weird dream. Those are things you might still see. But usually we can reduce the dosage from 10 milligrams to like 6 milligrams, and those side effects kind of subsides. So it's very low in which we can control and titrate to effect.
So what else should we be consulting the pain management team for?
As you mentioned before, pancreatitis, that would be one. CRPS, complex regional pain syndrome. Post-surgical pain lasting more than expected. So I would say chronic pain will be anything more than 3 months. Ehlers-Danlos and all the sequelae of that. Severe functional GI pain. Those are erythromyalgia. Those are things, fibromyalgia. Those are things, or AMPS. I think that should be pain team should be consulted early on, because when you start hearing these things like pain doesn't make sense, the labs are normal, you've done all this exhaustive blood, everything looks normal, I think, and the pain is still present, I think calling the pain team. And that's why we're there. It's a pain team approach, a biopsychosocial approach we kind of use to kind of address that pain.
I have another category of pain that I was wondering about. It might be just, too big for the discussion here, but so sometimes we run across our patients with opioid-induced hyperalgesia. We have patients with chronic pain syndromes that have to be on opiates all the time, and they seem to have just an overabundance of pain with, things. How would you approach that? Is this something that we should be doing by ourselves, or is this like well within the realm of our pain?
That's one specific situation that you consult the pain team for. because the treatment is the winning down, and to assist the family and the patient in winning down successfully, we have to use other adjuvants, like I said, ketamine, Presidex, lidocaine, to be able to cut down to actually get the improvement in their OIH, or opioid-induced hyperalgesia.
Amazing. So, yeah, it sounds like there's sort of conditions and like patient histories that should raise our little spidey senses to maybe get the pain team involved early. Is there anything that you wish that primary teams knew or sort of incorporated into their approach when it comes to treating sort of pain conditions? I think about like sickle cell and cancer as sort of two situations in which kids experience a lot of pain. But are there things that we should just know that you think about all the time?
For me, when it comes to sickle cell or any kind of cancer pain, what is your home regimen like? What have you tried at home that's worked before you get to the hospital? Because that will paint a picture of what was likely to be successful. Versus like you were using the old same one size fit all that when it comes to the hospital, or this is used that before, we're going to use for the same patient. Every patient is different. I think using like asking the patient what has worked before and they kind of replicate that and using that as a foundation versus like using a one size fit all approach.
Yeah, I like that. Don't reinvent the wheel.
And actually, that actually brings me up to kind of our next thing that we're going to talk about. And it's, how do we approach kind of chronic opioid use? And so some of these patients, for example, like I'll tell you what works, and it's a lot of hydromorphone, for example. And so that we have to be a little bit cognizant of how are we using these medicines and how can we prevent kind of chronic pain on these medicines requiring high doses, chronic opiate use, all of those types of things. What are those risk factors that we need to do to prevent that? How should we be approaching this when we see our patients and really kind of trying to meet in that perfect Goldilocks area of the right amount of analgesia without creating problems down the line?
That is where multimodal analgesia kind of comes into play, right? We saw the foundation, the ibuprofen, the Tylenol. Don't just rely on the opioids, right? That's where gabapentin, the Lyrica, the neuropathic agents come into place. To go back to sickle cell, 40% of sickle cell patients have neuropathic pain. So if you're just treating that medication with just opioids, it's going to lead to that high doses that scares every one of us. So that's why you have to start implementing gabapentin from the jump, so that at least address neuropathic components, right? And then you can have the opioid for the nociceptive pain. So having a balance, I think that's how you kind of prevent to get into those high opioid levels. And if you get to those high opioid levels, it's like, what can we use now? Sometimes you got to reset the receptors. You can use buprenorphine, you can use opioid rotation, which is switching from one opioid to another, or using something like methadone to kind of help us wind down over time, because that has a component of an NMDA receptor in that regards, if the patient has just been exposed on high opioids. And that has a less abuse potential too.
And are there any risk factors specifically that we should know about regarding people who could be at higher risk for chronic pain, higher risk for chronic opioid use?
So pre-existing anxiety or depression, previous painful procedure that's not been well managed. Usually those are the ones that's more prone to having chronic pain. High opioid use that's been on, like you said, on high opioids without any taper plan. Usually before you have any surgeries, we would like to wean your opioids down to lower setting, because now the setting has been reset. That if you come into surgery on high opioids, you're going to have to go higher than that. And then lack of any kind of physical therapy, deconditioning. Deconditioning, that means just laying in bed. Like I like playing video games, but playing all day, not moving. Motion is lotion. That will amplify your pain. And then just social stress or the trauma of being in the hospital itself. Medical mistrust. Those are things that can actually cause increase in your pain by amplifying your pain signals. And that's where the role of our pain psychology actually is very essential, in which kind of help us kind of give them the coping skills, because most of our children have passive coping skills. They know, like, if I just ignore it or just sit down, that's fine. There's no way of moving forward and pushing through. And that's why the passive coping skills and active coping skills that the pain psychology offer is very essential. So those are the risk factors that we try to address in a multimodal approach, which is just biopsychosocial, pain psychologist, physical therapy, and then a pain physician with the medications. So everything has to work together in one.
One time I had listened to a talk about how acute pain becomes chronic pain, and a lot of discussion on the plasticity of sort of these pathways within the brain. Also, at the same time, maybe the use of medications like SNRIs early on may help sort of alleviate some of these areas. And sort of as you're talking about like some of these mood disorders, which increase people's risks, like where do you see the use of medications like duloxetine and or what's the other one, venlafaxine, and sort of some of these disorders?
I think they play an essential role, and we've seen studies in patients that come for spine surgery that gets a one-time dose of Cymbalta before the surgery actually have less opioid consumption. So they play a role. The issue is like in the pediatric population, the dosage 20 milligram, 30 milligram, 60 milligrams, you can't go lower than that. So most of the patients I've tried in my practice have side effects in which we can never be able to win them down. So I'm very, very reticent to initially start it unless that patient is it. I think for diabetic, neuropathic, I think the data is excellent for Cymbalta. For some back pain in adults, the data is excellent for Cymbalta. But you have to just be very judicious because you cannot win it down to the lowest. There's no suspension for it, like in amitriptyline, in which you can go down to 3 milligram, 1 ml, 2 ml. Like with Cymbalta, the lowest dose is 20 milligrams.
Yeah, that's a super helpful practical point. I forget that some medicines aren't suspensions. We talked about multimodal control. We talked about sort of using a biopsychosocial model of pain. Any other things that clinicians can do to help reduce the risk of developing chronic pain?
I would say having a conversation with your patients and with your family is like the pain is real, but it can still be functional. Just because the pain is there doesn't mean everything else shuts down. Because my goal when we come to our clinic, any kind of pediatric pain clinic across the country, is to make you functional. Sometimes we want to put the pain in the background, not in the foreground. And that is pretty much, I think that's one thing we kind of like, we kind of say, pain, don't use the number as a way to treat the patient, treat the whole body, treat the function. Like, are they going to school? Are they sleeping okay? If they're making all those things, achieving all those goals, they're doing well. You do not look at, the number is 5. Yes, my 5, it could be your 7, but are they still functioning? So we're trying to treat the function. That's my main goal. The number usually is the last thing to go down. The function is the first thing you're going to see. And that's how I kind of talk to the family. Okay, he's sleeping well. He's going to school. He's hanging out with his friends. Has he mentioned his pain at all? Oh, he hasn't mentioned it at all. But when you ask the patient, boy or female, he's going to say it's a 7. But they've done more activities that they've done 3 months before.
I like that. I have one final question also kind of about the family dynamic from that end. Your pain psychologists, they also work with the parents? Because I wonder, it's so hard as a parent to see your child in pain that some people go head over tails, go to all ends of the earth, to try to just give my kid a medicine to make him feel better because my kid's in pain. And that's really hard for them to handle. Does that come up at all for your conversations? Does that come up with your psychologist as group therapy? I was just curious.
Yeah. Speaking of that, there was actually a study in one of the Notice programs, I can recall, in which they just offered like a CBT type education program to the parents only for about 6 weeks. And they look at the pain scores of the child, and they saw a reduction.
That's awesome. Yeah.
So there are data out there in which the family education is very essential, because the parents is one. If you're like asking a kid every time, are you in pain? Are you in pain? Are you in pain? Their reflex is, sorry, I'm in pain. But if that's what we tell our family, do not ask them what their pain score is. Do not ask them this unless they give you that information. And with that, they're able to see a reduction, because they're able to push through and be more functional. And that's what we kind of aim for. So I think data is out there, like family education is very important when it comes to pain.
No, that feels like a great note to end on.
Manny, thank you. We finally reached our kind of last point, and we want to just recap for our audience a little bit, some take-home points. Anything that you think, really, if you listen to this whole hour, what should you take away from this talk?
I would say, don't treat the number, treat the function. Yeah, pain is more than a score. Focus on the sleep, the school, the social life, and the movement. Pain is psychosocial, right? You can't fix it with medication alone. A good pain psychologist, a good physical therapist is what is weight in gold for rapid recovery of function in patients with chronic pain or even prolonged acute pain.
And then for our listeners, do you have anything you'd like to plug? So any websites we should go to, any societies we should check out, anything that we should know, or easy things on people's phones to use when they're trying to do pain? I don't know, anything along those lines.
Okay. So there's an urgent need for pediatric pain physicians. So right now there's less than 100 board certified pediatric pain physicians in the country. So I think Society of Pediatric Pain Medicine has programs, webinars to kind of offer for pediatricians, residents to kind of, if you want to join us, it is a rewarding field for me. And I would like to have more pediatric pain physicians. They can do either pediatrician, PNRR, anesthesia. Anybody can be a pediatric pain physician.
Awesome. Well, thank you so much. We're going to send all our listeners there. We really appreciate you coming on the show.
Okay. Thank you very much, guys.
This has been another episode of the Cribsiders.
It's for the kids!
Get our show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter at our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Hartley Lidsky, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
I've been Hartley Lidsky.
And this has been Chris the Chi Manchu. Thank you and good night. And of course, if you made it to the end, you're going to be blessed with another poem written by AI. This one's titled The Language of Hurt. Some pain speaks loudly with tears and cries, while some hide silent beyond brave eyes. In pediatric hallways day and night, we learn to read this language right, through faces scale and colored bands, for those too young to understand, through watchful eyes on those who cannot speak, whose pain signs subtle, bodies weak. First acetaminophen an old friend tried, with NSAIDs close by its side, dosed right and time to stay ahead, before the pain curve climbs with dread. Distractions magic, breathing deep, cold packs and stories help pain retreat, while bubbles float and screens engage, turning hurt to a distant page. 4 fractures, burns, and surgeries planned, multimodal approaches close at hand, from nerve blocks placed with careful skill to ketamine's brief dissociative thrill. Opioids measured, neither feared nor free, used wisely where they need to be, with families counseled, questions heard, disparities addressed with every word, for chronic paths that might emerge when acute becomes a lasting surge. Early teams with many minds may help before the pain entwines. This is our task with every child in need, to honor hurt with gentle deed, to treat the pain they cannot hide, and walk with courage by their side. Good night, guys.